Ar-Rahim, ladies and gentlemen. I'd like to express my deep thanks for the privilege. It's very careful, but he did everything for that and treated very cheaper to start my presentation. Thanks a lot to the Bashir, and thanks a lot to the committee that organized this important issue, scientific issue about diabetes. Ladies and gentlemen, things are changing, particularly with the recent guidelines, particularly from from ISAD, and even when cardiology and medical cardiology awareness of diabetes. Sorry for this technology. What we are trying to, for this half an hour, we need to give some details about recent guidelines about diabetes. First of all, this is my definition for the Al-Khobar physician 2019. Now, if you read the textbook about diabetes, you'll find it all things which are really now not relevant to the definition of diabetes. What's really now important that diabetes is a chronic catabolic progressive hyperglycemia state. You don't speak anything except about micro complication and macro complication. And what's really the management? Simply avoid hypoglycemia and weight gain. And what we are looking at for about cardiorenal axis of protection. Nobody now is speaking about HbA1c, nobody is speaking about what are the goals, but the most important thing to speak about cardiorenal axis protection to avoid and delay what we call it micro and macro complications of diabetes. Some people ask always this question, why it's so difficult to treat diabetes type 2? Before 10 years or 15 years, if a patient came with the HbA1c, for example, 7 or 8, and his fasting 210, we'll give him glycoside, glycoside, denderide, metformin. But now it's really totally different. Let us see what's going on. This is by Professor Lobovitz, who is an NDA president. What he said about diabetes is totally different. If you go carefully about what's really diabetes, for him, that once you diagnose diabetes at 0 time, that's what you call it insulin resistance. And insulin resistance, if you all of you are aware of that insulin resistance is because of obesity, is because of hypertension, is because of atherosclerosis, among. For that, once a patient has insulin resistance, you can predict that he will develop hypertension, will develop MI, will develop diabetes. And more important than that, was really important of beta cell function. Once of the diagnosis at 0 time, there is 50%, which we call it basal apoptosis. That if you give medicine like sulfonylurea, labinclimide, glycoside, within 3 or 5 years, there will be completely zero response, because what we call it beta cell function deterioration. And this is very important for us to give possibility of treatment if you consider this one and this one. This one is a very nasty insulin resistance, can predict cardiorenal protection and can predict MI, CVA, and other micro and macro complications. In 2021, type 2 diabetes, this is from ADA 2021. What they say that it is no longer now, it's just a HbA1c. Patient come to me and say to me, my HbA1c is 6 or 7, I will let get so impressed. But I don't know what's going on about his cardiovascular status, his nephrotic status. For that now, no longer can be predicted for type 2 diabetes for HbA1c. We need to look for microvascular complication, macrovascular complication. Not only that, but what they are looking for, recent advances, RCT trials about how to protect cardiovascular, how to protect the vascular. And these outcome studies came from 2016 up to 2020, confirming that no medicine can be given to a patient with type 2 diabetes unless there is a reduction in cardiovascular, there is protection for the left. For that, this one changed completely what's going on. Give you more details, go for this really very important issue that been published in 2020, 2021, that if you diagnose diabetes at 0 time, risk for cardiovascular risk factors like hypertension, like obesity, like dyslipidemia, all of this started at before 15 years of diagnosis. If you look at development of atherosclerosis around 10 years before diagnosis, and microvascular complication 2 to 3 years. What's really important from this slide that I'm not dealing with patients with type 2 diabetes alone. I'm dealing with patients with all complications, micro, macro, and risk factor like hypertension, like obesity, dyslipidemia, and others. For that now, we should not think carefully, oh, HbA1c, not at all. We need to look more what's going on in prevention and protection of diabetes. For that, really look carefully to this slide to know that really what we now have medicine, how to prevent cardiovascular, how to prevent the problem, that's really very important. And another recent study we published in 2020 confirming that there is what we call it silent or asymptomatic cardiovascular disease, which is around 44%. And 50% or 40% of people of diabetic, really they have clinical cardiovascular disease. Patients come to me, I will not be happy to see HbA1c, but I'm really happy to screen the patient because 40% of diabetic patients have already cardiovascular disease, which is the utmost important thing for me as a endocrinologist or diabetologist or general physician to look carefully about the 40%. More than that, to look carefully what we call our subclinical cardiovascular diseases, which is around 44%. This really very important slide and very important issue. What is really that? Once you have a problem in heart, you will have kidney problem. This is what's called a vicious circle. Once you have renal injury, myocardial dysfunction, vascular stenosis, and this what we call predisposed, what we call diabetes, frequently causes macrovascular complication, like MI, like a stroke, and microvascular complication, like nephropathy, neuropathy, retinopathy. For that, really utmost important time to look patient with diabetes. I will not look for diabetes alone, but what I look for heart failure, I would really look for nephrological process, which is really that occurs both the heart and kidney by itself at the same time. This is I got it just before 10 days from the ADA, the Diabetic Association, that what we're really looking about is really utmost important, really early recognition and early prevention. I should not see patient with diabetes with MI. I should not see patient with diabetes with CVA in the chair. But what I want to see diabetic patients very early, at stage 1, stage A or stage B, like risk factor, diabetes, prediabetes, hypertension, dyslipidemia, metabolic syndrome. This is the utmost important thing. More than that, social life, like tobacco, alcohol, itching, diet, history of cardiac disease. This is really the role of a nephrologist, the role of a cardiologist, the role of a general physician, and also the role of endocrinologist and diabetologist. If I be successful for this stage, I should try not to go to stage B, which is long-standing or poorly controlled diabetes. Because once diabetes is really developed, you will have microvascular complication, particularly microvascular complication, which is predicted for cardiovascular, for renal and even recent study by Professor Nano from Royal College of Physicians that really microvascular complication can do everything for diabetic patients. Having said that, I took this one again from ADA for 10 days, that what we can recognize that it should be recognized very early. Whatever you want, early recognition and close monitoring. I should not see a patient that after 6 months, I should see. No, I should be really careful in monitoring and follow up what you call it the appropriate treatment for type 2 diabetes. Look carefully again, this is what you call it now a vicious circle, that once you develop diabetic kidney disease, so if you look at for type 2 diabetes, you are developing diabetic kidney disease. If you develop type 2 diabetes, you're looking for heart failure, we are looking for MI. For that, it's really very important. Don't go only for this. It is a really vicious circle. Once you develop diabetes, you will develop diabetic kidney and you will develop heart failure. And this is a recent study in 2014 developed by endocrinology issue that really once you develop heart failure, there is 40 to 40% will develop diabetes. Look carefully what I'm trying to say. Once you develop heart failure, there is 40% to develop diabetes. And this is what we call this glycemic insulin resistant state, because patients with heart failure, they are insulin resistant and they will develop really type 2 diabetes. And again, once you develop type 2 diabetes, you will develop heart failure. This really, the combination between the two is a very nasty and a very poor prognosis. When you develop diabetes, you will develop heart failure. But this issue is how to tackle or how to diagnose heart failure, which is really very important. And look really carefully, this is a very interesting study that 35% of patients with type 2 diabetes have already undiagnosed heart failure. It's not only for diabetes, but go beyond that for the heart failure, it's really more than 35%. Why we are now speaking about this whole issue? In 2015, there was a big analysis of 4 major long studies, randomized control studies, the CME-PD study, Accord study, Advanced study, and VET study. I was one of the members for the CME-PD study when I was working in the UK. We're trying our best to make tight control for diabetes. Accord study, they see even normal glycemia or tight control. In Advanced study, the same thing, and the VET study, the same thing. Look about basal HbA1c 7.1, 7.5. Let's look about even the numbers versus the HbA1c. But what they were looking from this meta-analysis of major 4 randomized control trials, there was minimal reduction of microvascular, but there was no reduction for macrovascular, which is really utmost important. And even the worse, that in Accord study, there was an increased mortality of cardiovascular disease. What's the issue? What's going on? And this made the FDA in 2008 mandates that we cannot give any medicine for diabetic patients unless there is a proof for the reduction of cardiovascular and renal function. For that, this is in 2019, and again from American Diabetic Association, what they make, they call it holistic approach. It's not diabetologist, it's not endocrinologist, it is not nephrologist, but it's really a holistic approach that all of them, primary care physician, cardiology, endocrinology, nephrology, which is really utmost important. I should make me proud that I'm only the person who's following diagnosis. No, I should, if I'm able to diagnose properly nephrotic problem or cardiac problem, if you just simply don't make yourself just be aware that this is really a simple issue. It's not a simple issue. It's go beyond nephrologist or cardiologist or even neurologist. This is really, again, very important issue. The American Diabetic Association and the ESAD and even the European Cardiology Society, what they want to tell us about, that if I deal with diabetic patient, go before diabetic patient. Go for risk factor like diabetes, hypertension, obesity, dyslipidemia. And think about that these really risk factors, which is really insulin resistance, there is endothelial dysfunction. Once you develop this, you will develop atherosclerosis. You will develop microalbuminuria. You will develop coronary artery disease. And once this issue started, now we develop macroalbuminuria that will respond to amine, stroke, other kidney diseases. And this is what we call it really. Start from here, and you will end by cardiovascular. Once you start from here, you will develop end-stage renal disease. And I want to stop this factor. I want to stop end-stage renal disease. I want to stop heart failure. I want to stop the kidney diseases and bacteria. This is not from me, from major association of diabetes, like American Diabetic, the ESAD, the European Cardiology, and all of these systems. Having said that, ladies and gentlemen, it's really for me, this could be the first time that we published in 2015, then later by 2022 adopted by the ADA. What is it? They're now speaking about anti-proBNP, which is the heart failure indication. Now what they want, that mandate that every diabetic patient from every 6 to 12 months they check anti-protein. Why? Simply because these patients are more liable for heart failure. For that, I need to screen not for HbA1c. Now, we still think old-fashioned. Now, beyond look for microalbuminuria, look for measurement of anti-protein, which is really the utmost important thing for diabetic patients, particularly type 2 diabetes. And this is 2019, 2020, we published by Royal College of Physicians, and they asked me how really to summarize what's going on. What I said to them really, what's really the purpose of evidence-based medicine from the major randomized control studies that have been published from 2016 up to 2019. What's really the main management of type 2 diabetes? Avoid weight gain and hypoglycemia, which is the most important thing. Avoid microalbuminuria, predicted for cardiovascular and neurovascular and even neurovascular. We need some drugs that cardio-renal protection. The utmost important thing is that SGLT2 and GLP-1 could be the best modality. Why? I'm not looking for drug company. What's really improving the quality of life? What is it? These two medications, there's no hypoglycemia or weight gain. These two medications, they have cardio-renal protection, which is really the utmost important issue in management of type 2 diabetes. Let us see now, again, this is from 2022 from American Diabetic Association guidelines. What's really the important thing for the reduction of diabetes complications? What is the aim of it? Lifestyle. Try to have to reduce obesity, look carefully for smoking, look carefully for modifiable risk factors, glycemic control, but more important, blood pressure, lipid, and agents with cardiovascular and kidney. Now, nobody is talking about HbA1c, but what we are looking more advanced than agents with cardiovascular and kidney benefit, which is really the most important thing. And this is, I endorsed it for Royal College of Physicians 2020, that the question is not whether to target postprandial or pre-prandial or fasting glycemia, but when, how, and what your goals. What is really the goal of management of type 2 diabetes? It's really what we call it cardio-renal prevention protection. And this is now really the most important issue if we think carefully beyond HbA1c. This is being published from American Diabetic Association just recently to tell us what's really the management of type 2 diabetes. 2020. If a patient with heart failure, think about SGLT2. If a patient has chronic kidney disease, think about GLT2. If patient has atherosclerosis, think about GLP-1 and GLT2. There is now no place for sulfonylurea at all. The place now is only for these two medications, GLT2 and GLP-1 alone. I will not go further for meta-analysis of these studies, but look for SGLT2 carefully, see the reduction of major acute coronary artery disease and the effect for heart failure. All of them, the Canvas study, the CLEAR study, the study, all of these studies prove that there is a renal cardioprotection. Go for GLP-1 again for all of these studies, sustain study, study, whatever you want to see studies, and again the aim that there is a significant reduction of atherosclerosis, significant reduction of cardiovascular disease, MI, and even CVA. It's only one now of the best modalities for reduction MI and CVA is really GLP-1. This is again, it's not from me, this is the case being presented by American Diabetic Association 2022. Look carefully about this lady patient, she's 55 years. She's overweight, very significant. She's type 2 diabetes for 10 years. She's on sulfonylurea, she was on DD before. The NPN was 180, which exceeds the normal thing. She's complaining of dyspnea and exhaustion. What now, if I look, they didn't give me any about HbA1c, they didn't give any. How you can help? Anyone give me an idea? Why are you this? I put this patient. Be careful about this patient, that patient is complaining of dyspnea and exhaustion. She had high anti-proBNP. What's really they want to tell us that really was trying to modify patient with 5 risk factors, diabetes education, weight loss, all of this, all of what we know about it. But the interesting thing that discontinues surgery, but there is no effect, no benefit from cardiovascular or renal protection. And what they initiate GLP-1 and then SGLT in order to prevent the release of atherosclerosis, heart failure, and chronic kidney disease that lead to atherosclerosis stage. And this is what we call a step-one approach. There is now no place in the recent guidelines for sulfonylurea or even DD before, because there is no renal protection, there is no liver protection, and there is no cardiac protection. For that, if you care again for the recent ADA 2022, heart failure, go for GLP-2. Chronic kidney disease, go for GLP-2. Atherosclerosis, go for GLP-1. And this is again recently been published by American Association of Clinical Cardiologists. What's going on? The combination of SGLT2 with SGLP1 may result in a greater cardiovascular benefit compared using even one or two. They need now the combination, which is really could be the best modality for reduction of cardiovascular and renal vascular. Having said that, and again, this is from the ADA guidelines, that if you have a patient with atherosclerosis, look only for GLP-1. The patient has chronic kidney disease, heart failure, go to consider GLP-2 inhibitors. And this is the conclusion that I push it for the Royal College of Physicians 2020. And this is now one of the really main things, that diabetes increased risk factor for heart failure in 1 to 3 patients. Early recognition, which is the utmost important thing as a tool for ADA and the American Clinical Cardiology. And what they are now using this as a screen for heart failure, and that's utmost important thing that every 6 to 1 year that I should screen for anti-proBNP and use a team-based patient. And never ever forget that what we call it cardiorenal protection as GLT2 and GLP-1. Let me summarize what's going on. This is an example, for example, of GLT2, the empiric study. And I want you to give an idea, is there any medicine that there is a reduction of 14% if I use empagliflozin? If I use cardiovascular reduction, 38%. If I use heart failure, 35%. Worsening of the reduction, 39%. And all-cause mortality, 33%. I give one medicine. This is not from me. This is a very strong meta-analysis that we published in the Journal of Medicine in 2015. Anybody give me any better medicine than this one for reduction of cardiovascular or renal vascular? Let me just see what's really changed from 2015 up to 2020 regarding the measurement of type 2 diabetes. Look carefully all of this from the American Diabetic Association and even ISA. First of all, 2015, we're talking about glycemic control. And perhaps you may use GLP-1 or GLP-2. That was in 2015. Look carefully the meaning of glycemic control. 2016, they called cardiovascular mortality benefit. Canadian and other recommendation in the European Society that could be best modality is either to use GLT2 or GLP. 2018, instead of cardiovascular, benefit in atherosclerosis and chronic heart failure. Again, the ADA and the others, they want to use to confirm that the best modality is GLP-1, GLP-2. In 2019, there was terminology called the nephroprotection and cardioprotection. This is really very important for me as a physician to look carefully for nephro and cardiac protection for prevention and stopping micro and macro complications. In 2020, independent of HbA1c. Now, cardiologists, they use GLP-1 or GLP-2 of non-diabetic patients. Cardiologists, they use GLP-1 even for heart failure, even for prevention of atherosclerosis, or even for advanced cardiovascular disease. Not even not related to HbA1c. Look about the changes. Only for 5 years, look for glycemic control. Now what we are looking independent of HbA1c, but we are looking for atherosclerosis, heart failure, or chronic kidney disease. This is really a continuation of 2016, 2018, 2020, 2021. First of all, as I said, 2015, 16, glucose lowering. Now, it is nothing. In 2018, incorporate an agent for proven protection to reduce cardiovascular